Hi, I'm Carrie, a brain injury survivor and a member of Bind.
And I'm Kezia, a stroke survivor and member of Bind as well. And today is a very special Thursday, and we're super excited to welcome not only our guest, but also for it to be our very first virtual episode. So I really hope you guys are all watching us on YouTube and can see the big difference between this episode and all our other episodes. So today we have Saul Enriquez, who is a registered nurse in wait, Rio. I can't
Texas.
say the right word today. Well, he'll introduce himself too, but he's a registered nurse and he is actually a professor at one of the colleges at Rio Valley, right? Rio Valley Grande. And we're super excited to have him here as a guest from Texas and teaching us a little bit more about his point of view as a registered nurse and his a lot of years in neurology. Today is not that best of my day with words, guys, but I hope you guys all watch the episode and enjoy it. So, welcome, Saul. We're so happy to have you here.
Welcome to Bindwaves, the official podcast of the Brain Injury Network of Dallas. I'm Brian White, Bind's Executive Director. On each episode, we'll be providing insight into the brain injury community. We'll be talking to members and professionals regarding their stories and the important role of Bind's Clubhouse. We work as a team to inspire hope, community, and a sense of purpose to survivors, caregivers, and the public. Thank you for tuning into Bindwaves. Let's get on with the show.
Thank you, Kessia and Carrie.
Yes.
Terry.
Yes.
Thank you for having me. I'm Saul Enriquez. I've been a registered nurse 26 years now. I got my bachelor's degree in Corpus Christi, Texas A&M University, way back in the late 90s. It was like my second or third career, but I felt like that's where I needed to go. Immediately on my very last day of clinicals, I was introduced to open heart massage and open heart CPR. And so I went straight into the ICU thinking, oh my goodness, this was an adrenaline rush. So I've done medical ICU, I've worked in the surgical ICU, I've done neuro ICU, I've worked in the coronary care ICU, trauma unit, and the burn unit, and then did 2.5 years in the ER. So I have extensive high critical care experience, which really has given me a broad arena of information. And now for the last 8 years, I've been imparting a little bit of my knowledge and experience to students here in the Rio Grande Valley. I'm currently teaching at a private college called RJV College in Far, Texas. I do reside in the Rio Grande Valley here in McAllen, Texas. And I'm really pleased to see that the nursing shortage has hit us very hard, especially after the pandemic. And so I'm able to help fulfill a lot of my students' dreams in becoming RNs. And so I'm excited that I'm able to be on here with you and share some of my experiences with you. So thank you for that.
Awesome. That is a lot. Open heart massaging sounds kind of scary, but I could see where that would be a rush as well. But so my question for you is, in your many years, let's say we're going to focus on neuro since that's kind of our little niche here.
Right.
Have you always just been in ICU and CCU? I don't know the difference. I know I was in CCU and ICU. I don't know which one came first. I don't really know I know what they stand for. I know. No, I actually don't. I know CCU is critical care and ICU is intensive care. Did I get it right?
Right.
Okay.
Correct. CCU involves coronary care as well. So one is related to the heart special, like the open hearts. Medical would be more pathology, disease oriented. Then you have the neuro ICU, which is traumatic brain injuries, whether they're external or internal. Then you have surgical intensive care, which is after any type of surgery. They have almost like a recovery area, make sure that they stabilize before they go back to the floor. And then we have the ER and the burn unit that I've also worked in. And what I tell my students, Carrie, is many times is when I'm teaching neurology, the neurology is like the roadmap of the body. And so if everything is controlled and managed by the brain, then everything will be affected if the brain has injury.
Mm-hmm.
And so I've always related that to a map of Texas, for example, and I say there's different ways to get from the RGV all the way to Dallas. But if there's one area that's roadblocked or damaged or there's under construction, there's other pathways that can be created to get to the final destination. So that's where the therapy comes in. Not only the allopathic physicians or the osteopathic physicians, but also nursing care. We come in and trying to reestablish those alternative pathways that can enable patients to recover back to close to where they were before the trauma started, or is that happened.
All right, and we call that neuroplasticity. I know more words than I should know as a stroke survivor, but that's
a good
good.
word.
It's good to learn.
I think that
I
part,
like the way I've always used one of my counselors in my day neuro program that used like a railroad station, like if So, but I like the Texas roadmap better. I think I'm going to start using that.
Yeah, I really like that too. I hadn't heard it that way, but I think it makes total sense. And honestly, Carrie, we learned a lot because we went through this, and we learned our recovery, and we learned through our actions. So, but I like comparing it to a roadmap that we just have to rebuild a way to get to our next place. I really like that. And actually, not only were we patients, but a lot of the time between our families, our caregivers, our supporters, it was a way for them to also understand. So how would you be able to, the way you taught us right now, is that the kind of vocabulary you use with the people explaining them what happened?
Well, yes, Cassia, because down in the Rio Grande Valley, we have a high amount of immigrants coming in. And so we have not only the non-high school graduates trying to better their life and fulfill their dream, but we also have Caribbean doctors educated in the Caribbean and in Mexico having trouble passing their TOEFL exam, and so they cannot pass their board exam. So sometimes they alternate and become nurses, and so instead of them restarting all over again, they just go the RN route. And so I've had 3 or 4 medical doctors in my classes, along with recent high school graduates. And so I find myself having to challenge the medically trained professional without losing my post high school graduates. And so it's really tough, but I also try to make sure that it's a learning environment so that they can be stimulated enough to realize that this is not just a lot of memorization, but this is life experiences. And I feel like when I'm speaking, especially about the brain, I've been able to not only impart knowledge to the LVN program, but also the RN program here. We have a transition 10-month program for LVNs to transfer or transition, over to the registered nurse level. And I've been a guest lecturer in that department 3 times now, and I've been able to impart to them what it takes from a nursing perspective to help a patient get to where they need to go.
Well, kind of talking about
It's
the
very
nursing,
exciting.
and on that, I guess one of my other questions I was trying to ask earlier, I don't think I asked it correctly, but so is being a nurse in neuro, ICU, CCU, whatever it may be, different than being a neuro nurse in the acute setting?
Yes, big difference in that we as nurses, number one, the nurse has to be very therapeutic and very understanding what's going on. Most of these treatment plans and recovery plans take months, if not years. And so if the nurse is not patient or sets up a therapeutic trust with the patient, then it's going to be the patient can get very frustrated with themselves. And if the nurse is pushing too far, too fast, and too hard, and instead of encouraging, causes frustration in the patients, then it can be counterproductive. So I find that in the neuro ICU, we have to be exceptionally therapeutic, very patient with them, let them know that this is going to take time. This is not going to be 7 days of antibiotics and you're going home, that type of thing. It's going to be rehab. It's going to require relearning different activities of daily living and things of that nature. So, we have to make sure that, and then on top of that, we have to also make sure that our patients are going to be safe. The top priority, I guess, for any nurse in the neuro ICU, especially after it's like a blunt head trauma or MVC, motor vehicle collision, then you have sometimes seizure activity that comes on after the fact. And so then we have to make sure that our patients are not going to end up on the floor. They're not going to end up with an additional injury, a hip fracture or arm fracture, because they were not secured properly and make sure that they didn't fall out of bed. So it's vigilance, observation, meticulous detail, safety reassurance, and things of that nature. Make sure that the patients are going to be taken care of, watched after, and secured. Make sure that they're safe. And that's what I teach my students, is that in due time, we'll see the recoveries. Sometimes it's baby steps, but it's okay. Baby steps are better than no steps. Hopefully that answers
Exactly.
a little
I
bit
think
of
what
the
you just
nursing
said that
perspective.
this is, oh
It
yeah,
does. Yes, it does.
it does answer a lot of questions. It also asks, I have so many more questions. But yeah, I mean, I think it's awesome that right now that you're saying that you teach your students and that you have so many different perspectives with, where they're from or what they've learned before. But I think that as a patient, that also is almost the same. Like we're also learning along the way with our injury and with our experience, and also of our family members. So
Right.
I think I related, and I'm not a nurse or a student, but I think
Right.
that's where we're at too. So I love that
Yes.
perspective.
Well, the internal and versus external brain injury, can result in the same type of damage. In my personal life, both my mother had a CVA about 6 years and 6 months ago, and she survived up until this past March. And she was bedridden, but we did meticulous care with her, and she was able to have very lucid days. And some days she didn't wake up, but there were times where she would ask and speak up. And so I was honored to have her in my home and take care of her. But then in 2020, right as soon as the pandemic was coming into the United States, my wife had a CVA. And so she had a stroke, and she was in the hospital for 30 days. And so we found ourselves at the time then, having to deal with this on a very from the RN perspective and the patient perspective, because my wife is an RN as well. And she found herself very impatient because being charge nurse, being in charge of the whole ICU and the floor, she found herself impatient many times, wanting to get up out of bed and wanting to do this. And then she finally had to come to terms that as a patient, now it was having to take the time to go back and recalculate, relearn, and do the baby steps again. Thank goodness they hit her. She was at work when the CVA happened, so they were able to immediately take her to the CT scan, and it was an ischemic CVA. That means it was a blood clot in the brain. So they were able to give her that streptokinase medication very quickly and dissolve the clot. And so she regained most of, if not all, her right-sided uh, abilities to move, I guess. The lack of movement, their paralysis, I should
Yeah,
say.
yeah. That I was
But then,
thinking
but
paralysis.
cognitively, she lost her cognitive abilities to remember a lot of the information that she had learned through her 25 years of nursing. So she had short-term memory and long-term memory loss, and ended up, with full disability. But at the bottom line, she's able to now get back to the point where she can drive. She knows where she's doing. She makes herself daily lists of what has to do that day. And so it's very important that we have to be a very understanding as the nurses and versus the patient. Sometimes we're both. In our situation, we were both, and it was very frustrating for her. But again, I had to be very reassuring. The nurses that took care of her and the rehab therapists were amazing. They all knew her from before the stroke. So when they saw what had happened, they were very therapeutic. Bedside manners were awesome, and so they were very understanding as well. So I guess it's a whole different paradigm when you start having to change your mindset, going from just the nurse taking care of somebody to being the patient. And now we can understand how the patients feel. And again, like I said earlier, that's how I'm trying to impart to my students that type of therapy.
Yeah. Well, thank you so much for sharing your story and your perspective as a nurse and as a husband and as a son. I think that's it's really important because, like you said, we not lose our perspective, but we kind of lose control of it to a certain extent. I mean, I had a stroke, and
Mhm.
um, it it's hard to be patient with oneself. I was 28. I went to
Right.
college. I mean, I was really smart.
You
I still
still are.
am,
You
right?
still are.
But it's really frustrating when I couldn't read.
Yes.
So yeah, it is very, very frustrating. But it's great. It's a great process and uh, success when you can totally understand it and you're like, okay, that's what happened. Now let's move forward. So I think it's really
Let's move
important.
forward.
Yeah.
And we have to be very careful, though, Kessia, that as nurses, we don't push our patients. And knowing that my wife was so energetic and she was so advanced, she was a lot smarter than I will ever be. And I had to make sure that I didn't push her too much too fast and that she was also very patient with herself and not let frustration creep in and ultimately with depression and whatnot. So yes, it's baby steps. And if we get back to 90, 95%, that is awesome. If we can get back to 75%, that's awesome as well. The bottom line is that, it's just everybody has their own story, their own abilities, and cognitive wise, we have to make sure that the brain heals. And that sometimes it takes longer for some people, but it ultimately will reach its maximum point, and we have to work with that.
Okay, thanks, Sal. I'm going to take a quick little break and just remind all of our listeners to go ahead and click that like button, that share button, and that notify button. Because he's clicking,
Awesome.
do all that. And Sal, just to kind of go back to what you were saying, I had a hemorrhagic stroke, and I had a
Okay.
blood platelet transfusion, so maybe that's why I went to both different ICUs or whatever. But I
Hmm.
also had some of what feel like you're describing. What they told me was impulsivity. I had a bed alarm, I had a chair alarm, I had all of that. So, and all the different personal, I mean, your family versus not versus, but and all the patients that you've seen. Do you
Hmm.
think that's one of the greatest challenges with a brain injury survivor, or what? What do you kind of? I mean, we all have to relearn. We all are start somewhere lower than where when the brain injury happened, or whatever it may be. And again, yeah, like you said, we all recover at a different pace, at our own pace. I was completely
Yes,
paralyzed on the left side. It's still a little not so good, but I
mhm,
walk around, I drive, I work, I do everything. But
right. I reassure my patients, Terry, that the brain recovery is multifaceted in that not only is it physical in that we're trying to get back to activities of daily living recovery, but it's also mental and emotional, and it can even be spiritual because people's emotions are affected. Like I mentioned earlier, frustration, depression can lead to suicide ideation if they're not getting back to where they thought they should be. And so it encompasses all the areas of our lives. So, the three spheres of our being. And so I try to reassure my students that as a nurse, we have to be very patient, of course, and therapeutic. And number one factor is safety for those patients. They have to be safe. They have to make sure that they are not going to do something outside of their boundaries and or push themselves that they're going to fall and hurt or jump out of bed or accidentally fall out of bed, I should say, and or develop seizure activity, and they're left alone and they're not monitored carefully. So yes, it's the brain in the healing process. It encompasses all different arenas, not just physical. And so you have the physical and the metaphysical, the emotional, and it's very important that as nurses we take the time to deal with all those aspects. If someone needs meditation, if someone needs prayer, if someone needs some sort of different therapy, then of course we need to be there for them. And so again, that's very vitally important as a therapeutic agent, promoting health.
Yeah, I just want to give everyone a heads up. We might have a little bit of a disconnection for a little bit. I hopefully it's not that bad. But I think right now what you were sharing was just, I think we have talked about that a lot in some of our previous episodes about communication and like the importance that sometimes our emotions get affected as well. It's not visual, but it's something that happens that is invisible, that it's hard to explain, right? Like we had a brain injury and now, some people cry more than before, or some people laugh more than before and have a difficulty explaining their emotions or their needs to people that love us. So it's a very important part of recovery that might take longer to heal. So I think it's very important. And I love that you express that to future nurses, because at the end of the day, those are the nurses are the people we spend the most time with through
Well,
our
yes.
hospitalized. So I love that. Thank you so much. I do would love to hear actually if you have any of advice. Well, right now you were talking about that, but also like if you have any like things innovative. I can't say the right words today, but anything that's new that's happening to a brain. You did share via email a new research, but is there anything new that you think is super important to be sharing to people that are going through their new
One of the thank you. That's an excellent question because I find myself, especially down here in the valley, we call ourselves the Rio Grande Valley, and we find ourselves that diet has a lot to do with not only the predisposed risk factors. If there is a familial genetic predisposition for, let's say, Alzheimer's or Parkinson's, that we can actually slow down those risk factors by what we're taking into the body. We can also, one of the key things in any med surg class and pharmacology class is going to be lowering the levels of inflammation in the body. Number one, top every disease that I've ever studied or come across has to, besides except for trauma, has to do with inflammatory responses. And so what I find is that if we lower inflammation at the diet level, at the rest exercise level, reducing those radical oxygenation species, then we can actually reduce the pathology in our bodies. Is that we can do that from the brain all the way down to our feet. Number one. One of the techniques that I've actually recently started implementing in my own life because of the amyloid plaque buildup history in my family, realizing that my mom had CAA, cerebral amyloid angiography, amyloid angiopathy, sorry, was one of these new techniques that it's called a photobiomodulation, and where they use the different nano wavelengths of the red light spectrum to, if it's introduced directly on top of the cranium here, for some reason now medical journals are conclusively saying that the wavelengths at 810 nanometers and 660 nanometers penetrate way down into the limbic system and actually stop the development of amyloid plaques. And coming from a familial genetic history of having Alzheimer's, getting up there, whatever I can do diet wise, photobiomodulation wise, exercise, things of that nature, then one needs to educate ourselves. And I bring that up in my classes. I said, research is now showing this. So I'm constantly in the NIH website looking for peer-reviewed journals, double-blind studies, sometimes even triple-blind studies. And so it's in AI today, Kessia, is absolutely changing the world of neurology. It's bringing technology into the point. I mean, for example, look at our new neighbor down in Brownsville, Mr. Elon. he is now actually working on implementing and has already implemented on a trial basis Neuralink, and so there are not only the ability to bring your thoughts to reality, but now you can actually bring your thoughts in texting for somebody who's fully quadriplegic or paraplegic. And so you have medications now that are coming to light. For example, clustamine. Clustamine has been recently discovered as it's an over-the-counter antihistamine, and it's helping with MS patients who have problems with demyelinization of their nerves. And so again, the technology is so cutting edge that by the time we get our textbooks, they're like maybe 2 or 3 years old. The technology is already way up ahead. And so it's a little, as an instructor, we have to continue to research, continue to find things and bring them to light, even though they're not in the books, but they're going to be at work when they hit the road running, so
No, I know.
it's
And
very important.
it's so exciting because if I think about it, like I've read books since my stroke. My stroke was 15 years ago, and I've read books of people who had strokes 40 years ago, and they were just stuck in a nursing home or an asylum and just said, "Duh, they had a stroke, they're done, they can't go." And now look at us today. We have grown so much in
It's
that
amazing.
amount of time, and hopefully we'll just keep growing quicker because unfortunately brain injury is here to stay. We can't
It
stop
happens.
car
Yeah,
wrecks and motorcycle wrecks or strokes. Not yet. Hopefully we can figure out how to stop strokes, but
right.
But I love seeing that your excitement to tell us. I am looking forward to this episode to be watched by many.
Yeah.
And also, it was so much fun to do, honestly. So we can hopefully have you back to
Yes,
continue
it will be an
teaching
honor.
us. Yeah, because you're really not only teaching nurses, you're teaching us and our listeners. And it was so much information. I had so many more questions to ask. But thank you so much for being here. Honestly, thank you so much to our listeners to sticking through our episode, and hope you guys have learned a lot.
thank you again.
All right. Thanks for having me.
And-
I appreciate it, Cassie and Terry.
Sure. And for all of our listeners, again, if you would like to contact us, you can email us at bindwaves@thebind.org or find us on our website, thebind.org /bindwaves. And of course on Instagram. Guess what that is? @bindwaves. So again, if you're interested in becoming a member or a volunteer, go there and check us out.
And obviously, like Carrie said earlier, just don't forget to press all of those like buttons. And if you would like to see us, you can check it out on YouTube.
And again, don't forget, every Thursday, you'll find us on your favorite platform. So until next time.
Until next time.
We hope you've enjoyed listening to Bind Waves and continue to support Bind and our nonprofit mission.
We support brain injury survivors as they reconnect into the life, the community, and their workplace.
And we couldn't do that without great listeners like you. We appreciate each and every one of you. Continue watching. Until next time.
Until next time.